the surgical techniques that we use for this procedure. So it was Erasmus Darwin that in 1760 initially described the techniques for corneal transplantation. However, it wasn't until 1905 when Dr. Edward Zurn first performed a successful human transplantation using a penetrating keratoplasty technique. This technique has changed very little in the last 100 years, with penetrating keratoplasty being performed for primarily endothelial dysfunction for 50% of cases. Penetrating keratoplasty is an excellent procedure yielding an optically pure cornea that tends to have a graft survival of 90% for at least 10 years, according to some reports. However, there are several downsides to penetrating keratoplasty. Those include high levels of corneal irregular astigmatism that often decrease the visual acuity of our patients and often necessitate the use of a rigid gas permeable contact lens to attain best acuity. There's also operative risks with the open sky technique, and there's long-term suture-related problems such as infections, as seen in this picture, or graft rejection related to these sutures. But by far the biggest side effect of penetrating keratoplasty is the loss of the structural integrity of the eye, leading to long-term risk of wound rupture and severe vision loss from minor trauma to the eye. So what would be a solution to reduce these risks? Would basically be to do a more selective form of corneal transplantation. DSAEK technique accomplishes this by eliminating the large wounds and eliminating the long-term complications related to sutures. In turn, DSAEK leads to a faster visual recovery, more predictable refractive outcomes with an astigmatically neutral procedure, decreased operative risks, decreased risks of infection, and most importantly, retention of the structural integrity of the eye. Patients that are candidates for this procedure are those suffering from primarily endothelial dysfunction. Those include Fuchs endothelial corneal dystrophy, pseudophakic bullous keratopathy, eye syndrome, and failed grafts. This procedure doesn't just treat the vision, but it also treats the pain associated with pseudophakic bullous keratopathy. What we do in this procedure is we selectively remove these diseased endothelial cells that have lost their ability to pump water out of the cornea by stripping Descemet's membrane, as is seen here, in conjunction with the corneal endothelium. We then have a donor cornea that we prepare using a deep lamellar cut, using a microkeratome cut. We then trephinate that donor cornea, and that yields a donor lenticule, as is seen here. This donor lenticule that has stroma, Descemet, and endothelium is then inserted into the anterior chamber and apposed onto the posterior stroma of the recipient cornea using an air bubble tamponade. Once those endothelial cells start pumping, they vacuum that lenticule on the back of the cornea and basically result in a new endothelium that clears that cornea, increases the vision, and resolves the bullous changes on the epithelium. So endothelial keratoplasty is a procedure that has been in flux. There have been several little changes in surgical technique that have led to multiple acronyms. In summary, DSAEK and DSAEK are exactly the same procedure. All we're doing is, with the AA for automated, we're using a pre-cut donor corneal tissue that has been prepared by the donor eye bank. Basically, the eye bank does the microkeratome incision and sends you the pre-cut donor corneal tissue. The benefits of using a pre-cut donor corneal tissue is that you have a more reliable donor lenticule thickness. There's less operating room time, and there's no need to have backup tissue in case the surgeon perforates into the anterior chamber doing the microkeratome cut. This is from Ocular Systems Inc. in North Carolina. This is what they send us. It gives us the diameter of that free cap, it gives us the thickness of that lenticule, and it gives us the endothelial cell count. This is a show quickly the steps of surgery. This patient has had cataract surgery. We then enlarged the corneal incision. We used an 8mm marker in this case to outline the area to be stripped off of Descemet's membrane. Here we see an irrigating Gorovoy stripper being used to score Descemet's membrane, and then as is seen here in a single sheet. Here you see that it's not coming all the way, so we do a Descemetorexis to take out the Descemet's, and then we use the irrigation aspiration to remove Descemet's membrane. Vision blue is used to stain and make sure no Descemet's is remaining in the central cornea. Donor corneal lenticule is then folded into a 60-40 taco after placing Helon on the endothelium and atraumatically inserted into the anterior chamber. Once inserted, the main incision is sutured closed, and the donor lenticule is unfolded, in this case using balanced salt solution with a cannula. This S ensures that this tissue is stromal side up, and then air is injected underneath the tissue to oppose it onto the stroma of the recipient cornea. This Lindstrom LASIK roller is then used to do fine tuning of the centration of the graft. Let's go through those steps a little bit slower. So here we see the Descemet being scored using a 25-gauge needle bent. And this is done by just gliding that needle without any pressure. Then we use a Gorovoy stripper to strip Descemet in a single sheet, as is seen here. This is, in this case, being done under Helon. So there's Helon in the anterior chamber in this procedure. The Descemet is then removed. And here, for illustration, you see the Fuchs goutte of that Descemet membrane. This tissue is then submitted to pathology as our specimen. So after that, you remove all the Helon from the anterior chamber. Here you have your donor corneal button with basically we've placed some Helon on the endothelium, and then we fold that posterior portion of the donor into a taco. We use these specialized single point insertion forceps that grasp the tissue at a single spot to reduce graft compression and endothelial cell loss. We then insert that tissue as atraumatically as possible through a 4mm incision in this case. Once the tissue is inside the anterior chamber, we secure that wound using a suture, and here we're unfolding using an air bubble, just for efficiency purposes. We then use the same needle that we used earlier to center that graft on top of the air bubble. Here you see that the endothelium never touches the IOL or anything, and then after the air bubble is placed, the anterior chamber is filled with air. Other forms of insertion that have been described are this method using a boost and glide. Here you see the posterior donor lenticule being placed on the boost and glide endothelial side up with Helon placed on the endothelium. We then advance that tissue into the glide, turn the glide upside down, bring it up to the 4mm incision, and go across the anterior chamber, grasp the tissue, and insert it atraumatically again within the anterior chamber. Here we see an anterior chamber maintainer keeping that anterior chamber depth. So this is just a video showing the fine-tuning using the Lindstrom LASIK roller. Once the anterior chamber has been filled with air, and that tissue is opposed onto the posterior stroma, we use this roller in order to basically nudge that tissue into perfect centration with minimal endothelial cell trauma. And as you see here now, that gap between the graft and the suture is gone. Another technique that has been described is the use of these venting slits in order to evacuate interface fluid. These do work. However, there have been some anecdotal reports of venting slit infections and epithelial downgrowth into that interface. So we try not to use them as frequently anymore. So the donor corneal button, as we said earlier, adheres by those endothelial cells start pumping water out of the cornea. perform an air fluid exchange, leaving a graft-sized air bubble in the anterior chamber, and we dilate the pupil. What this does is it decreases the risk of a pupillary block from the air tracking behind the iris, closing the trabecular meshwork, leading to a high pressure. We then have the patient lie supine for an hour in the postoperative care unit and give the patients instructions to lay supine for 24 hours with bathroom breaks and eating breaks, otherwise supine looking up at the ceiling. Patient seen at day 1, 1 week, 1 month, every 3 months afterwards. All sutures are removed at 1 month, and those steroid drops are tapered down to once a day after 6 months. This is for Dr. Herbert Stern. You see an anterior segment OCT showing excellent donor adhesion with minimal interface scarring. Here you see histology of this interface. Again, minimal interface scarring, and in these histology slides, I've left some pieces. I took these pictures because there's a little bit of Descemet remaining in the interface, just to show how clear that interface is. So one side effect of DSAEK is a hyperopic shift. This shift has been described as occurring from insertion of a meniscus-shaped donor lenticule that is thicker on the edges, thinner in the middle, which changes the posterior power of the cornea. This in turn leads to about a diopter to a diopter and a half hyperopic shift. This is important when performing a phaco emulsification DSAEK combination procedure or a DSAEK triple, where you would want to adjust your IOL power for a -125 to achieve a near ametropic result after 6 months. So DSAEK has its own list of complications. Most common complication is graft detachment. At Duke, on our review of our initial 800 cases, we found a 6% risk of detachment. Of the ones that detached, 95% reattached with a second air bubble, done in the same slit lamp as I'll show in this video. Patients are instructed or are educated about symptoms of a graft dislocation being a painless decrease in vision that's sudden down to the hand motions range. If this occurs, they're asked to call us and set up an appointment and not to panic. This can be done non-emergently at the slit lamp or in the operating room. This video shows a graft that has been detached. You see by that shadow of the slit lamp. 30-gauge needle is used to inject air in the anterior chamber. That opposes the graft. And then a venting incision using a super sharp blade is used to reposition or recenter that graft. After this is done, you see a beautifully centered and well-attached graft. After this is done, the patient's again laid supine and the same instructions apply. We dilate the pupil, regulate the pressure so it's not too high, and the patient is seen the next day. Other complications include interface aids, as is seen here. We're not quite sure why this occurs. Maybe there's some chatter from the microkeratome plate. A rare complication is dislocation of the DSAEK lenticule into the posterior chamber. This has been described in patients that don't have a capillary bags ungular apparatus that is intact. It's happened in aphakics, ACIOLs, sulcus IOLs, and sclerally sutured IOLs. This, of course, requires the assistance of your fellow retina specialist, where you do a lenticulectomy, pars plana, and then you see penetrating keratoplasty for this patient. So special cases of DSAEK. DSAEK has been successfully achieved in graft failure. Here you see a beautifully clear corneal transplant. Here you see the corneal transplant scar from a prior penetrating keratoplasty that failed. And then a subsequent DSAEK, you see the DSAEK margin right here, clears that graft beautifully. Now what we do is we use a smaller lenticule than the graft in order so that lenticule doesn't have an interface to nudge, no interface irregularity for it to adhere. Post-trabeculectomy, these cases are those stab incisions and keep the patient supine without doing an exchange of the air. We just leave the air in and have the patient lie supine, and then we see them downstairs, make sure the pressure's not 100. Post-glaucoma tubes, these are a little bit easier as the air bubble tends to stay a lot easier within the anterior chamber, maybe due to the surface interaction of the air not going through the tube as easily. So here you see an excellent outcome in a patient with double tubes. We've also done it in triple tubes and quadruple tubes. Works very well. This is actually very common. Tubes tend to cause the cornea to decompensate very, very regularly, especially when those tubes are long and hit the endothelium when the patient rubs or blinks. Here you see a beautiful outcome from a DSAEK in an anterior chamber intraocular lens eye. As I said, these are a little bit more challenging, but they're still very doable. We've even done it in aphakics, and it works well. But the techniques change a little bit. Here you see an excellent outcome in a pediatric endothelial failure patient with a beautifully clear cornea after 6 months. In summary, DSAEK has several advantages over penetrating keratoplasty and is quickly becoming the standard of care for endothelial dysfunction. Once again, I'd like to thank